My name is Mike Potter, and on behalf of UCSF's Clinical and Translational Science Institute and the San Francisco Bay Area Collaborative Research Network, I'm delighted to welcome you here. It's been more than 3 years since we last held a meeting in person, and a long time wondering whether and when we could meet in person again. And well, here we are now in a world transformed by COVID-19, even as the pandemic continues and with thousands of lives lost globally each day, and a long list of other challenges like climate-related disasters, homelessness, gun violence with daily mass shootings, including those in Half Moon Bay and also in Oakland this week, and oppression and inequity in all their forms. So given all this, I'm really inspired by each of you who have made the decision to join us in person today, and I'm really delighted to say that in addition to many UCSF faculty, students, and staff, over 120 individuals representing 70 different organizations have registered to join us throughout the day. And I take your presence as a reason to hope that together we can make the world a better place. So the goal of today's meeting is to reflect on the last 3 years of living with COVID and to begin a conversation about research partnerships that can help us address the many challenges we face. The COVID-19 pandemic has upended traditional approaches to research with the need for immediate action by community leaders, often running far ahead of the science. What have we gained? What have we lost? What can we do better? How should we be imagining or reimagining community research partnerships in the future? I think that each of us here today is an expert based on our own experience. And my hope is that today we can have a day to learn from each other. So to get us started, we'll have a series of presentations by people who I would describe as healthcare heroes, who have built innovative programs and partnerships that have created new knowledge and saved countless lives. In the afternoon, we'll break into groups for conversation and networking, and if you stay to the end, you'll get to hear our keynote lecture by Peter Chin Hong that you won't want to miss. So now I want to introduce Hilary Seligman, who's the co-director of CTSI Impact, and then Dr. Harold Collard, UCSF's Vice Chancellor for Research at UCSF, for some words of welcome.
Hi, everybody. Woo. Impact is really excited to be co-hosting this meeting for the first time today with SFBayCRN, and thank you to Mike for his leadership and for allowing us to partner with you guys today. Also, thank you to Saji Mansour and Amy Williams for all of their support in making this event happen, and to Laura Schmidt, who is the co-director of the Impact program with me. So the Impact program is new. We seek to support UCSF researchers in doing work that makes a difference in the real world, rather than sitting behind academic firewalls in difficult to decipher, peer-reviewed manuscripts that nobody really ends up reading. It's the truth, right? So what do we mean by making a difference in the real world? We mean policy change and social change. We say that's the work we want to do, but the way we publish our work doesn't often ladder up to policy and social change. So how do we change policies and systems as scientists? By making sure that key evidence reaches the people who are empowered to create and implement healthcare policies and solutions. Evidence that reaches them when they need it, in the ways they need it, and with actionable recommendations. We think that authentic partnerships between researchers and real-world decision makers in healthcare systems are critical for the changes that are needed to realize health equity, population health, and healthcare quality and value. And we're also convinced that we as researchers and scientists can learn to be more sensitive and more responsive to the needs and constraints of people who are making these decisions in the real world, including in our own healthcare systems. So the IMPACT program stands for Impacting Policy by Accelerating Translation. We support the UCSF community and its partners in doing this work better. And we look forward to talking with you more throughout today about impact-oriented science and learning from you about how we can best move science into the places where it's really needed most. Thank you. And now I'm supposed to say, I now turn it over to Hal Collard. Thank you, Hal.
Thanks, Hillary. Thanks, Mike. Good morning, everyone. I want to make just a few brief comments. I'm Hal Collard. I'm our Vice Chancellor for Research here at UCSF. And before that, had many year connection to CTSI and many of the people and operations and programs in the room. I want to say just a few kind of deeply felt comments to the group. And I thought about this on my delayed commute from the East Bay over here, so I hope all of you were not too affected by that. This is not a performative introduction. I'm here on behalf of myself and what I represent, which is the research organization and community of UCSF, to say that I feel our work is centered on what's being discussed here today. And I look to many of the people in this room, including you, Mike, as I like the term healthcare heroes. And I think we as an institution need to continue to center our work around the type of programs and needs and perspectives that are represented here today. So I just want you to know that I'm here to participate, to listen, and to take what's discussed here today and think about how do we, as an organization, help achieve all of the goals that we have here today. So I think my other main task for the morning is just, again, on behalf of myself and the institution, to say thank you to all of you for being here. Thank you to Mike, who I've learned a ton from over the years working with you at CTSI, and I really am so appreciative of what you bring to this. I've been to this meeting before the pandemic. It's just a terrific meeting, and I'm glad we're all back together again. And thanks to all the other people here who I know were really central to organizing and making this possible, which really is probably everybody in the room. So I'll be here most of the day. I look forward to, please come up and introduce yourself. I'd love to meet you, hear your perspective, and I'm excited to get started. So thank you, Mike.
Thank you, Hillary. It's been great to work with you and Laura on organizing this meeting, and thank you, Hal. I also want to thank our CTSI leaders, Sharon Chung and Christine Rasler, for supporting this conference with funding, and especially also to our dedicated staff and program managers, Saji Mansour, Amy Williams, Rana Barar, Erica Wang, Jairo Ceballos, and Helena Rega for making the event possible. Let's give them a little bit of applause. And you can stand up if you're in the room. If you don't see them here, if you see their name tagged, please thank them throughout the day. And also thank you in advance to all of our moderators, facilitators, speakers, and poster presenters. It's no small task to get things organized and put together a presentation for an event like this, so I thank you very much. So now I would like to introduce Dr. Tung Nguyen, who's been a national leader in community engaged research for over 2 decades, Tung, right? He now serves as UCSF's inaugural Associate Vice Chancellor for Research with a focus on inclusion, diversity, equity, and anti-racism. And he also leads CTSI's Research Action Group on Equity. Thank you.
Thanks, Mike. Mike told me my job is to get up here, introduce the speaker, and sit down. And as you know, most of you who know me, I can't follow instruction or directions. So welcome to the conference. Before we start, I'll take the moderator prerogative and tell you a little story and then make one analogy. So the story I have was when I was a young researcher, believe it or not. Dr. Dilip Ball, who was a big leader at the California Department of Public Health, told me, he said, well, Tung, you guys do really great work at UCSF, except that whenever I have a question I need you to answer, you have an answer, but it never answers what I want in the way that I want. And so I can't use anything you guys do. He just came right out and told me this. And that's stuck in my brain my whole life. I mean, it's like, yeah, what's the point of doing what we do if the people who are supposed to be applying it can't use it? It's, I think Hillary has alluded to. And I'll start with an analogy, which is always a dangerous thing to do, but I'll do it anyway because I'm an analog guy in a digital world. I work with a lot of academic researchers, and often it feels like they are the ones who have the best toys to go anywhere, like they have the electric vehicles and the satellites and the GPS. But they don't actually go anywhere. And I work with a lot of community leaders, and usually it feels like they are the ones who know where to go, but they don't have the latest tools to get there. But they get there anyway, on foot or on bike, using incomplete maps and a compass. And I ask myself, do I want to have a lot of toys and never go anywhere, or go where I want to go with the people I like in suboptimal conditions? And the purpose of this conference is to merge those two conditions. We want to be able to go where we want to go together using the best possible tools. I trained during the AIDS pandemic, in which the community activists breached the walls of academia. Not too far from here, 32 years ago, the Second International AIDS Conference was held, and ACT UP, the AIDS activists, actually fought into rooms like this and disrupted all the scientific presentations. So they breached the walls. And I'm hoping that the challenges that we have now, the COVID-19 pandemic, the racism epidemic, and all these extreme inequities, will leave something good by destroying those walls altogether. So there's a reason why nobody wants to live in castles anymore. So this session is about building a sustainable bridge. It's a bridge not breaking down the walls, but it's okay. For academics to inform evidence-based public health policy. I'll introduce the speakers first, all of them. They will each present for about 15 minutes, and then we'll have questions and answers. So the first speaker will be Dr. Erica Pan, who is California State Epidemiologist and Deputy Director of the Center of Infectious Disease in the California Department of Public Health. And she will be presenting on community-based organizations and academic partnership to create California's COVID-19 response. Presenting on workforce cultural humility training will be Dr. Kelly Taylor, Director of Community Engagement for the UCSF Pandemic Initiative for Equity and Action, and Dr. Robin Ortiz, the Director of Development of the Felton Institute. Dr. Ortiz isn't able to be here today, but Dr. Taylor will talk about their work. And last but not least, presenting Health Equity Requires Action will be Dr. Kim Rhoads, UCSF professor and founder of Umoja Health Partners, and Dr. Monique LeSarre, Executive Director of the Rafiki Coalition. So, without further ado, Dr. Pan.
Lower this. Good morning. Thank you so much. It is such an honor to be here, and great to see so many familiar faces, some of whom I've only seen in 2 dimensions over the last 3 years, and yeah, really nice to reunite. I think, you know, as far as building bridges, I feel like I'm coming home a little bit too, because my clinical training was here at UCSF, my infectious diseases training. I started my public health career in San Francisco, so it's really nice to be back and really nice to be in person. I think the other thing as far as bridges, you know, when this pandemic first started, we had a really strong Bay Area Health Officers Network, and Dr. Tomas Aragon, who's here today too, and our state health officer, was in San Francisco at the time, and I was in Alameda County at the time, and we were amongst those 7 that had to make that really hard first decision about issuing those stay-at-home orders. And we thought that was one of the hardest decisions we had to make, and there was all this evidence from 1918 and the pandemic then that that's what made the difference, and we knew that was, you know, we had evidence to support that. But how we made decisions about how we reopen and what to reopen first was so much harder. And I think I'm going to talk today about a few just key examples of partnerships we've developed over the pandemic, and really looking forward to building more. And I think just making all of these connections over time. Next slide. So I was asked to talk a little bit just about, where have we been as a state? Actually, I'm just going to hold this so I can see too. Where have we been as a state? What has been our strategy or how we've been looking at a framework for our response to this pandemic? So over the course of the last 3 years, I guess the other quick background thing I should say is, so I was in Alameda County for the first 6 months or so. At the local level, and then I moved to the state level in July of 2020. So I have been there ever since. It feels like dog years in a way, and it also feels like I just got here at the state level. But we did come up with some overall arching areas and strategies to try to kind of bucket the way we were thinking about our response over time. So of course, communications is one of the most important things for anything, like even day-to-day operations, but especially in a crisis and emergency. And there's a lot of mantras about you can never communicate too often or too much. So we really tried to put a lot of investments and energy into effective communications and engagements. We had something that got set up called Vaccinate 58, which many of you have seen a lot of the media and campaigns around the state. Really tried to engage community-based organizations as much as possible, really trying to hear people from where they are. But as you all know, that was one of the biggest challenges in this pandemic. We never anticipated the polarization that could be there, and just the challenges we've had in some of our public health messages and communications. So that's where, again, we really rely on academic partnerships to help support the policies that we're making, and being able to do that both directly, but also having you kind of all validate with your voices and your research and your evidence is super helpful. And of course, vaccines were really the key, right? So end of 2020, early 2021 is when we first could start rolling out vaccines and really wanted to achieve high levels of community immunity through effective vaccination strategies. And we went from these extremes very early on, having very scarce supply, very difficult decisions about who could get vaccinated first, trying to again have community advisory committee to provide input into that. And then after we got through several waves and we finally had enough, then it was really trying to work on those really important last those really important populations that still we needed to gain their trust. And we still needed to improve our vaccine confidence. So continuing over time to improve that, and having now more vaccine than people, and seeing unfortunately very low booster rates right now, and really working on that communications to improve booster vaccination rates. And then, of course, my big job as the state epidemiologist is really be looking at our data all the time, and looking at, what is just our baseline surveillance data, looking at cases, hospitalizations, and deaths, looking at test positivity, trying to determine which of these are the most helpful. Of course, cases and test positivity tend to be more of the leading indicators, and of course, that's really changed over time with the, thankfully, increased availability of over-the-counter antigen tests. So now we look at things like wastewater surveillance and other sentinel surveillance to really try to look at consistency over time of what the data is looking like, and using all of that testing as well as far as early detection, looking at whole genome sequencing, really looking at variants over time. So all of those things really to help monitor the scope and the magnitude of what's going on in the trends. Which takes, again, a huge effort and a lot of partnership with a lot of you as well. And of course, equity, thankfully, has been a huge foundation of our state response. And I think this has been supported at the highest level, of our administration, and certainly within our Health and Human Services Agency and department. So really working to reduce and drive and eliminate these disparities that we've seen, unfortunately, over and over, and again, seeing them with boosters, but working to even distribute and allocate our resources based on Healthy Places Index and other things, and we'll talk a bit more about that. And then, of course, the other key area where the partnership with all of you is so crucial, and again, I'll give some good examples in a few minutes, but having policies to really mitigate, right? Especially before we could have medical countermeasures, we really had to do these things around having people stay at home, having people distance, wearing masks, all of these sort of community mitigation efforts while we were working on getting the vaccines and medical countermeasures and treatments. And having the science around that. So we have a lot of basic science for these things, but then how do you demonstrate the impact of those in the community on a population scale, which is, as you all know, a huge challenge. But again, really grateful for the partnership we've had with academics to look at all of that and really do our best that we can on making the best decisions we can with very little time to make the decisions. And then, of course, schools are just a foundation of all of our homes and communities. I know Dr. Bardock is going to speak later, and I'll also highlight that a bit later too, but really making sure we're looking at evidence in schools. How do we keep our kids safe, keep them learning? We've obviously seen the impacts, all of us, even those who are very resourced, seeing the impacts of having distance learning and staying at home for that long on their mental health, on their education and development. So wanted to make sure we highlighted that throughout our pandemic as a priority area to attend to. And then, of course, the more traditional healthcare systems, right, which are, especially early on in those huge surges, and even what we saw this last winter with the RSV and early flu season, the huge surge impact on overwhelming our hospitals, overwhelming our clinics, and how do we monitor those impacts? How do we as a state help support with staffing? Again, policies that can be more flexible in the moment to allow you to take care of your patients. And this is also the area where once we start to get treatments, working on test to treat, helping provide some safety net telehealth resources, all of those kinds of things are in that category. And then of course all of it has to be coordinated, which is no easy task in a state of 40 million. So that's kind of just an overview of the big categories and some of our thinking around over time of the response. Next slide. And then I thought I would just highlight, a few key collaborations that I've been most involved in myself that are just, I'm so proud and excited about the investments we've made and the partnerships we've made. So we very early on, I think actually even before I got to the state, there were some high-level interest from the governor's office. There actually were some citizen scientists that were helping with a lot of data and modeling, and CDPH started to cobble together a modeling team, pulling a little bit from internally, quickly trying to hire some people, but also very importantly developing a collaboration with UC to have a UC modeling consortium. So we started this, it more officially launched in the spring of 2021, and at the time Kirsten Bibbins-Domingo was kind of our co-collaborative lead, and this has just been a really crucial partnership to help inform our modelers, and also just really get a lot of helpful input from modelers across the UC system on all of our various, in all of those different categories. I think we've had very helpful input from different partners. Next slide. So I think the other really, the devil's always in the details, right? How do you actually do this effectively? I think one of the key things we did was develop data use agreements so that we could have a few key UC modelers really be able to be behind our firewall, like that got brought up earlier, and have that agreement so they could do timely analysis of our data. Over time, as you also know, we were able to get our COVID data on an open data portal, so it's even more accessible more broadly, but really having kind of a few key individuals who could really help us with timely questions. We're gonna get this next tranche of vaccines and we wanna do XYZ, how can you help us kind of think through this? So we had these different kind of committees. We had strategy and oversight, we have a data committee, and then we have program development and research priorities. And all three of these committees kind of have worked, on the nitty-gritty of each of those parts, but then, pulling that all together in order for us, again, to have periodic webinars where we can really talk through key policy issues that we're struggling with and get input and presentations from various academic partners and also from our own team to show kind of how they're thinking about things. And this has also been really instrumental in pulling together our CalCat, which I'll show you some snapshots of in a moment, which really is an ensemble of different models from across the UC system and across the country and the globe. Really, it's an ensemble. But this is really key to develop this and get a little bit of funding for as well to enable us to have a few key staff on our side and a few key staff on the UC side to really enable this governance structure and be really clear about roles, clear again about those data use agreements, and being able to fund a little bit of that work. Because again, I think early on there was a lot of volunteer work, but that's not possible for 3 years straight. And so we're really glad again that we're able to fund this over the last couple of years. Next slide. So what are some of the meeting topics? I mentioned we've had these periodic seminars. I think at one point they may have been weekly. I think now they're bi-weekly. But again, Dr. Bardock has presented at different times and other partners on school-based transmission. What are different mitigation efforts we can do? How often should you be testing? What's the evidence between 3 versus 6 feet distance? Just all of these really important questions we're continued to struggle with over the course of the pandemic, and really trying to pull together that data and analyze it and look at both real sort of studies that might have happened right here in California, but also looking at the literature altogether. How to model waning immunity, which is of course our biggest challenge at this point, like that we continue to have waning immunity and of course more immune evasive variants. So Maya Peterson and Marm have been key partners, and they're two of the modelers that actually do have, we actually fund a bit to do some behind the data wall to do other kind of ad hoc analyses at times as well. And then we've had a seminar where Dr. Aragon presented our overall science agenda, looking at the CDC science agenda and kind of aligning that, looking at some of our State Department of Public Health priorities and getting your input on those. So those are just a few key examples of topics we've covered. Next slide. And then we were also able to provide a few small grants for 4 modeling-related projects that would just happened over this past year. And then we have a related effort addressing long COVID. We've been able to, as we've had other situations, talk about MPOX response. And then this is the website if you want to look at past topics. Thank you. And past recordings. Next slide. And then this is CalCat, which I briefly mentioned. And now over time, we've been able to add flu projections as well. So I encourage you, if you've never seen this website, to go to it. It's CalCat. I think, yeah, the link is down there. But you can look at COVID cases, hospitalizations, and deaths, both sort of forecasts and then scenarios. And then it's an ensemble of models from, again, not only some that we've developed internally, but a huge ensemble of all of the others as well, and flu as well. And then during this last season, we were able to look, you can't do it on the website, but we can look at sort of the stacked impact and projections of flu and COVID together. Next slide. So this is kind of a snapshot of what the hospitalizations are looking like. Thankfully, right now, the trend is decreasing. Next slide. And similarly for flu, you can see this very high peak we had as flu hospitalizations and the projected trends. And again, always a huge variation, but that's why it's always helpful to have these ensembles to see kind of what's the middle sort of ensemble of all of these projections. Next slide. And then another thing we have just launched more recently and was part of the governor's Smarter plan as far as dealing with COVID-19 as we move forward to future phases out of the pandemic. And so we were able to get funding with the Smarter plan for the California Collaborative for Pandemic Recovery and Readiness Research. And this is funding policy relevant public health research. So we have an executive steering committee. Dr. Priya Shet has been involved actually in many of these other both with the modeling, and she was actually more kind of, we had hired her internally as well to help with a lot of our modeling work, and now she is helping lead, or she is leading the CPR3 on the UCSF side, and just been a great partner and collaborator. Next slide. We have a few priority areas that we developed with our steering committee, and 2 of the key ones we just issued some RFAs on the 17th are the impact of this pandemic on children and adolescents. As a pediatric ID doctor and a parent, this is really important to me as well, and mental health, which obviously there's a lot of overlap there, but those are 2 key areas, and we'll be issuing about a couple other areas in the coming weeks or months, but I can allude to also really being able to look a little bit more at behavioral science and impact of communications on policy and compliance with different kinds of recommendations, as well as social determinants of health. Next slide. And then just briefly, another kind of partnership, there's a lot of these National Science Foundation PIP grants. They're predictive intelligence for pandemic prevention, and so one of the groups we're partnering with is multidisciplinary, multi-institutional, mostly based in Chicago, but we're the other C. They're working with the City of Chicago Public Health, State of Illinois Public Health, and California Department of Public Health. And so really looking again at kind of what are stakeholder input into like what are the key policy questions we have, what are the kinds of data we have or the data we need to help make decisions and make them in a timely way. Because I think as was alluded to in the analogy even, we often can do very academic things that take a lot of time, and we want the science to be perfect. And during this pandemic, we didn't have that time. And in the next pandemic, we're not going to have time. So really trying to develop these more timely relationships, databases, data use agreements, and sort of algorithms to really help us with critical decision making. Next slide. So at one of the recent workshops, again, they had multiple different input from different public health partners, and we tried to do kind of a backcasting exercise, thinking like, when we get to 2030, what do we want to say we can do now that we couldn't do before, and then working kind of forward from that to where we are and how do we get there. It was a great iterative learning process. We're going to have a webinar soon to hear more about the kind of how they tried to digest the input from public health stakeholders to the academic partners doing that. So it's just another great example of really important collaboration so that the academic and analytic work can really inform policy and get input from policy. Next slide. So there's so many lessons learned, right, about all of this. I think data use agreements and access is really crucial and always takes much longer and many more lawyers and other than we all would like. But it's important to protect our residents and our patients. Making sure you have key project management and coordination. Also very crucial when you have a lot of really busy people on all sides. You really need people who can, keep the work moving, keep the communication moving, document decisions, et cetera. And of course, like any other initiative and effort, you need high-level leadership support. So again, we were grateful early on that at the governor's office level, we had support to do this and investment in these efforts and developing that infrastructure to make it easier and easier over time to continue and sustain these collaborations. And on that note, when budget is bad, we need to continue advocacy for financial sustainability. So we are really looking now to work on finding efforts to maintain and grow this infrastructure. And then it's already been said over and over that timeliness is really important. Both public health and academics, I think, are not always used to working on such an urgent, timely timeline, and that is what we need to do when we have these infectious disease and public health emergencies. Next slide. So I will just close with, this is actually a real bridge in eastern China. And the first slide I had showed the ivory tower, it's the Tower Bridge, but just trying to think about this, I think a lot of frontline clinicians, I think about academics as one ivory tower, and I think public health being kind of the bureaucrats in another tower, and we've been building these bridges, and I think the reality is it's much more complicated than just one bridge, right? There's all these different connections. I hope forums like this really help stimulate even more of these cross-collaboration of collaborations to really continue to work to integrate the information and the data to really help inform our policy and interventions. So thank you all, and thanks for all your work as well.
Next, Dr. Kelly Taylor, please.
Good morning. It's an allergy, not COVID, so just for folks who might be wondering. So my role, as Tung announced, was the Director of Community Engagement for the UCSF Pandemic Initiative for Equity in Action. It was a group that was stood up in response to COVID-19 under the Institute for Global Health Sciences. I'm also faculty in the Division of Prevention Sciences, but I think as Director of Community Engagement, this has been one of my most rewarding roles throughout the pandemic. So today I'm going to talk about our collaboration with our community partners around standing up a training for cultural humility for contact tracers and case investigators. My co-presenter today couldn't make it, Dr. Robin Ortiz from the Felton Institute, but they're only one of 6 partners that we had during this collaboration. So I'll present some of her challenges and successes and lessons learned as well throughout this talk. As you can see, there is a photo at the bottom left-hand corner on my side that shows COVID vaccination for Umoja. And my colleague, Dr. Rhoads, this is her group, and I purposefully picked that slide because her work is an exemplar of what community engagement should look like in the work that we do with communities that's non-transactional and sustainable. Next slide. So this is a quote from Jennifer McGee-Avila. It says, when you listen to people's stories, sometimes you can't help but see how the influence of social determinants of health or structural racism have impacted their life or their trajectory or have placed them at increased risk for certain things. And so because we know that certain groups, certain marginalized communities are more impacted, it only makes sense to collaborate and work with those communities to be able to implement sustainable and impactful programming to address their community issues as they've defined them and also as they see the need. Next slide. So in this, I'm sorry. This one? So in terms of cultural humility principles, I'm not going to get into a lot about what cultural humility means, but some of the pillars around cultural humility, it is a concept that was created by two graduates of UCSF. So I'm very proud of the work that they've done in regards to cultural humility. But for the purposes of this talk, we're talking about the aspects of reducing power imbalances, lifelong learning, partnership, and institutional accountability. And those are sort of the four pillars, along with self-reflection, that guided us in this work in co-creating a cultural humility training for California's contact tracers and case investigators. And you can look up the work around cultural humility to get more information and definitions and more applications about how this principle was used in other work. Next slide. Oh, I'm sorry. I got used to hearing you say next slide. I just so what was the scope of the issue and why cultural humility? So as you know, for folks reaching out to communities, but particularly around COVID-19 and contact tracing and case investigation, we must have programs that instill trust. And what we learned early on is that contact tracers and case investigators were not trusted partners in the community. They weren't connecting with clients impacted by COVID. They weren't getting the information that we needed to recommend public health recommendations that people would actually enact. And so we kind of took a step back to see what can we do to sort of mitigate harm and also really try to reach communities in terms of wanting to hear what we have to say at minimum about COVID-19 and at maximum to implement the recommendations we had about keeping them and their families safe. So contact tracers deliver healthcare messages that must have skills and competencies to deliver the messages. So that was the other piece, right? So we know that as public health professionals, we're trained to deliver healthcare messages and public health messages, but our community members may not have the same type of training that we have, but also still have valuable messages to deliver. So in that collaboration, we wanted to be able to instill culturally and linguistically appropriate messages, and we wanted to have a trauma-informed approach. And we could not do that in the isolation of our ivory tower. We really needed to engage community to accomplish that. In addition, person-centered care must be respectful and responsive to individual preferences, needs, values, and ensures that these values guide all care decisions. And we also needed the expertise and lived experiences of community to help us understand what those experiences, values, and needs look like. So, to that end, success demands a collaborative response. And trust comes easier between people with shared languages, experiences, and ideologies. That's something we already know in our work that we do as public health professionals. But we also need to recognize and elevate that people in the community are experts in their own lives. This is not we're the experts in this space and we need your help. This is, we're experts with different sets of expertise. And so this program was designed to flatline that hierarchy as much as possible between academia and public health partners in the community. To that end, community-based organizations are trusted sources of information and support, particularly for marginalized communities. They have sustainable models and ongoing services that communities already access, and they're equipped to deploy people and services quickly. So in order to create and deliver a cultural humility training, we co-developed these materials with the community. And so we did have guiding principles and guiding frameworks to do this. We use, for the medical folks out there, we use the Kern model to help us guide the medical model that's used to create curricula for medicine and medical students. But we use that as a guide to frame how we would workshop each of the areas that were necessary, we thought, to deliver this training that were decided collaboratively with community. We created supplemental training materials to ensure that all contact tracers and case investigators and graduates of what we called our virtual training academy had the core skills and cultural humility to effectively fulfill their roles. So, as you may remember, the state deployed or redeployed or seconded folks from all walks of life in the public health infrastructure to be able to stand up our contact tracing and case investigator programs. So you may have people from attorneys' offices, fisheries and wildlife, other sectors of the government that had no idea about any public health programming, let alone how to connect with community. So that was part of our goal, was to make sure that we level set for all of our partners, no matter what your background was, to be able to understand how to work with an engaged community and understand the public health impact of what we were trying to accomplish. We implemented a supplemental training program and developed communities of practice to enable transformative learning across diverse California settings. So along with the training that we developed, we also had weekly communities of practice broken out by subgroup, whether you're a supervisor or a contact tracer or case investigator, that we were able to infuse the information that we needed and cross-train folks so that they were consistently up to date with things around what the latest information was around COVID-19 epidemiology and some of the nuts and bolts that they needed. But also we used the information that we gained from the outreach as contact tracers and case investigators to train and use as examples for folks in our communities that were doing this work of best practices, as well as practices that didn't sort of meet the standard, and how we could reteach folks how to engage and address community. So as I said, the scope of work had 3 phases, and the first phase was engaging the community-based organization stakeholders. And so what I want to really emphasize in this work that was super important to us is that we remunerated community-based organizations. So we got a grant so that we could fund community-based organizations to participate in this work. And through a competitive RFA process, we put it out to the state of California, and CBOs applied to participate with us in this cultural humility training process. So each organization that was ultimately selected, we selected 6 throughout the whole state, geographically diverse as well as diverse in who the populations they served. And we gave them $75,000 to participate with this program. They also got to practice these skills. So we already had other virtual training academy courses, and they were able to attend those courses, get practice in things like facilitation, get practice in, around things like building rapport, et cetera, but they also taught us in this process. In the second phase, this is where we used the Kern model to design a 2-day cultural humility training program. And we got feedback from community through listening sessions and workshops to refine that content. And so you can see here where the 4 sessions that we held with our CBO partners that were selected: introduction to the curriculum development framework, and Kern, determining the gap, so what is it that we needed to address, identifying goals and specific measurable objectives, and then finally determining educational strategies and resources for implementation. And then finally, in phase 3, our CBO stakeholders co-facilitated the training that we co-created. And I don't have the luxury of time today to show you, but we had both live training and asynchronous training, where CBO partners also delivered some of the video content, addressed the communities who would receive these trainings, as well as participated in training in the live content sessions. So I know this is a busy slide. Feel free to take a screenshot if you feel like it would be helpful, but we did have a pretty specific logic model in terms of what we were trying to accomplish and with our partners and where we wanted to get in terms of outcomes. And so, as you know, as researchers, we need data, so we continually, revisited this to make sure we were on the mark in terms of achieving the goals that we had designed for the training. So just quickly, you can see the screenshot on the right. Some of our colleagues today in the audience were a part of this group, but these are our community-based organizations and our UCSF and UCLA partners that participated with us. You can see our CBOs at the bottom here, Sacramento Covered, Disability Voices United. We found that, many of us feel like we have some cultural context around racial and ethnic communities, but did not know a lot about some of the challenges that our partners who are living with disabilities faced, and so that was very fruitful in terms of a collaboration. The Fresno Center, Felton Institute, Esperanza Community Housing, and Visión y Compromiso. And so our content included defining cultural humility, implicit bias, impacts and responses, effective communication, motivational interviewing, building collaborative relationships, and advocacy skills. And our trainings were initially 12 hours, a total of 3 days, 4 hours each, and then we had asynchronous trainings as well. And we've continued to tailor that based on need. So these are some of our successes. We've had over 1,000 people enroll, 713 completers, and you can see the expansive counties that have impacted, and I think that we also have ones that are not represented as of last week's training. The training was also done in Spanish and in English, which, as you can imagine, is not a light lift, but we felt we needed to have language concordance in our work for our communities that are most impacted. So in terms of sustainability, we delivered a 2-day training at the American Public Health Association, abbreviated version with our community partners that co-presented with us. We still have an ongoing relationship with our CBOs. We have funds to extend this work to other UCSF departments, including nursing and emergency medicine and others. We have a training delivered to jurisdictions outside of California. So what we found with this was that there were a lot of spaces around the country that needed this. They Googled it, found it, and asked us to, could we deliver that training to their partners? So we've delivered to the Maryland Department of Public Health and other community-based organizations as well. And then we have a grant to develop training for researchers and public health practitioners. So in order to continue this work, we want to seek funding to continue to collaborate with community partners around tailoring cultural humility for other areas beyond COVID-19 so that we can elevate patient-centered care, whether it be in nursing practice, in medicine, or other allied health professions. So my colleague, Dr. Ortiz, wasn't able to be here, but some of the nuggets that she would like to pass on in terms of their experience collaborating with us around kind of 3 things: inclusion, experience, and exposure. And so the flat line model, as much as possible that we could create it around this, was helpful for community-based organizations to be able to come to the table as equal partners with their expertise. So we listened as much as we talked, and I think that can be hard sometimes for academics. In terms of experience, we created the opportunity for their staff to learn new skills and our staff to learn new ideas about how to engage with community. Their diverse perspectives obviously added a rich amount of information to our content and the way we delivered information. But this experience also helped them in terms of exposure. So our colleagues have said they've been invited to do talks with other universities about this work. They've been invited to sit on panels. They've been invited to participate in grantsmanship opportunities, as well as UCLA asked them to host 2 interns in public health at the undergraduate level. So we may not recognize the ripple effect of the work we do with communities and how much it means to their sustainability, but that's also a part of this non-transactional way that we should work with not only our CBOs, but also community in general. Thank you.
Okay, I'm going to turn it over to Dr. Rhoads and Dr. LeSarre for another example of really best practices. Whatever you want, I don't care. Yeah.
Go ahead. Test, test. Hey, y'all. How's everybody doing? Are we gonna have some fun in this presentation? Everybody awake yet? You got your coffee? All right, you ready for us? You ready, Dr. K?
I don't think they're ready for us.
I don't think they're ready for us. Y'all didn't know.
Okay, so we're actually going to introduce to you Umoja Health, but really through the principles that were shared with us by Baba Arnold Perkins, who was the chair of our community advisory board here at UCSF Cancer Center for the last 10 years and a member for the last 17. So you're not going to see a lot of pictures of what we do. I want to recommend that you go to umojahealth.org and you'll see a lot of pictures of the different events from the different jurisdictions. But that said, I want to echo some of the things that have already been said here today. So my previous work before entering into this space with COVID, working on disparities in cancer was really focused on flipping big data sets and looking at the quality of care and correlating that with outcomes and finding repeatedly that the disparities in cancer in solid tumors and liquid tumors could be explained by differences in the quality of care. Nonetheless, as was mentioned before, these were just important in terms of impact factor, but not in terms of impact on real lives. None of it was adopted. Yes, there are tons of lessons learned. There's lots of best practices, but have any of them been implemented at the system level? I think the answer is no. So that really gave me the impression that it's possible that we might be doing things wrong.
You think? Maybe.
And in fact, some gaps have gotten wider. I mean, you know, and we came into COVID with this, I don't think the people in this room came in this way, but a lot of people got this big aha moment about, oh my gosh, disparities are so terrible. But the populations facing disparities in COVID are the same populations facing disparities in cardiovascular disease, diabetes, obesity, cardiometabolic issues, and cancer. So it's all the same. It's just a repeat with a different disease. So we're going to talk a little bit about how we built First United in Health District 10, which is the Southeast sector. Whoop, whoop, 94124, 94134. And I forgot one, 94107.
Yes.
Okay.
Much disputed, actually. 4 months.
And as I mentioned before, we're going to use some of the instruction from Baba Arnold Perkins to guide how we think about the work and the work that we've done. And before I start, I want to acknowledge that Umoja Health operates in San Mateo, San Francisco, and Alameda County. And I want to acknowledge I see Miss Wilma Batiste from our faith community partners, and Miss Lisa Teeler, who leads Umoja Health San Mateo, in the room. And shout out to our Alameda County friends who couldn't be here today.
Is that me? All right, y'all. So I wanted to take you on a little bit of a story as I've been listening to all of this. We've been flashing back a lot. Tomas, I heard you're here. I don't know where you are, but somewhere back here. Hello, Tomas. Because we were actually co-chairing SF HIP at the time, and then all of a sudden he went away, and then he went to the state. So there was a whole big journey that we've all gone through: mental health, physical health, psychological health, all spiritual health, all these things. Our families have really been impacted, and our community has really been impacted. So I've been thinking a lot about that as I've been sitting up and listening, because we've actually, at Rafiki, we've been part of all of these conversations from the beginning. So basically, Dr. K and I were already working on projects here at UCSF when all of this happened. And we came to a screeching halt at Rafiki. We have our HIV positive transitional house, we have our CAM clinic, acupuncture, massage, chiropractic, for all free for the community, mental health services, navigation, wellness services, yoga, massage, movement, drum healing, art and healing, all of these, and all of the other cultural, spiritual events that we did, as well as participating with UCSF and different research projects. All of those things we were doing, all of that came to a screeching halt when the mayor, our amazing mayor, London Breed, shut us down. I think it was March 17th. Yeah, that seems to be traumatized in my brain. When I'm like, I'd come to the same conclusion that morning, like the Friday before she did it. I'm like, okay, we got to shut down. And then she did it and made it a lot easier on me. But my staff were all looking at me like, wait a minute, what? We don't want, what? And so this is part of the journey that was what we really realized in my community and in our Hunters Point community. Folks were kind of like, this is all a fraud, this is a fake. So we had to really figure out how to get the messaging out. Dr. Rhoads called and she's like, hey, maybe we can go to the parking lot at Rafiki. What do you think? They've got this thing going on in the Mission. Why don't we do the same thing for Bayview? And so we started to work on it. It was about 7 weeks of planning, all in the middle of the night, you know, all day, all night, all the time. I remember at Rafiki, this is what I want to get across to you all for a nonprofit, especially a Black-led, now woman-led nonprofit, is that we have been incredibly under-supported economically over the years. So I didn't actually even have a computer with a camera. I didn't have a computer with a camera for Zoom. My first Zoom sessions were with Dr. K, and we were like, which room? Where is it? Because we kept getting switched. So this is what I'm saying. The technology that we had to deal with in 3 years has been astounding. So what I invite you to do when you're working with your community partners is actually to check in. What you know, Tung said it earlier, you know, we're sitting here, we're mortal and pestle. We're not even pen and paper. You know, in many of our, does this making sense, what I'm saying? So check in with who you're trying to talk to and how you're trying to work with them to see what they even have to work with and how much their staff is able to do the work. Kim used to put up a sign, I'll be back in 5 minutes on the Zoom link. Because we'd be getting coffee. But this is the thing, we didn't even know how to use a chat. Y'all, do you remember that? Maybe, maybe not. I didn't know how to use any of this. So in the middle of all this, then unfortunately, George Floyd was murdered. Well, let me be clear, he was lynched. And then the news kept showing it again and again and again. And I think some of you may have heard me say this before. Literally, I'm in a meeting on the same day with UCSF, not with Dr. K, with others, and not one mention.
No, that was on me.
Oh, you were in there. Okay, so then I was putting in the chat because I was sitting there upset. And so in this moment, we have to recognize what is happening for community and how we might be traumatized and not able to continue a meeting as usual based upon what was going on. I didn't want to look at all these images, but you couldn't even turn on the TV without seeing this literal lynching of this Black man. So.
Well, and you know, to the point of having to take action, one of the things that we did in the United in Health D10 effort, which was 4 days of mass testing, you may remember, was at a time when there were no swabs, no reagents, no access to anything. You had to have exactly the right reasons to get tested in order to be eligible. And,
that's right.
And what, you know, again, hat tip to Diane Havlier for coming up with the idea of doing low to no barrier access to testing and PCR and antibody testing at the time. But the night, I think the video around George Floyd came out the night before our first day on site, right? Or it was the second day. So we were concerned that people weren't going to show up, the volunteers, because they would be downtown, you know, in the protest.
Was getting shut down.
Yeah, remember? Mm-hmm. And so, you know, one of the things that we really tried to motivate people was to say that actually acting against COVID is social justice movement. So some people need to be downtown protesting, but some of us need to be here trying to save our people also. And so that's part of how we took action and used that as inspiration, that some of us have to be around in order to see what happens on the other side of whatever was going to happen with the George Floyd issue. So after all is said and done, a lot more said than done. I want you guys to really hold on to that because we talk a lot. We talk so much about health equity. I always want you to be asking yourselves the question, what are you doing to advance it? Okay, so as we got started and evolved from United in Health D10 by request over to Alameda County into Umoja Health, we then came back to San Francisco after that. The one thing that was important for us to keep in mind is it's the 400th year anniversary of the enslavement of Black people. Like, why does this matter? Because Black people are not immigrants. And the original United in Health had been focused around a community really kind of made up of immigrants and this idea of people who live in one particular place in a city. And the history of Black people in this country as slaves is disbursement, dispersal, separation from each other, from families. We're not looking for where did Tia move or where does Abuela live and that's where we're going. We got told you're going this way, the rest of your family's going that way. And if you look at the maps of the major metropolitan areas, you see Black people are dispersed all across these cities. They're not clustered necessarily in one area. So we knew that our efforts had to actually be mobile. And that's really how we initiated the pop-up model.
That's right. Oh, go ahead.
Well, our first pop-up, and in fact, I would argue the first pop-up in the Bay Area for COVID services was on June 27th, 2020 at Family Day in Sunnydale.
Black Family Day, Black Family Day in
Black
Sunnydale.
Family Day. And we were invited. So the community actually picked up the phone and said, hey, can you bring more testing? And we were like, oh my God, what? They want more Q-tips up the nose? And like they want that? So when I got that call, I know you got that same call,
Yes.
right? We were on it. We're like, how are we gonna make this happen? So in partnership with SFDPH, Jackie McWright, another strong Black woman, we brought testing right to the street on Sunnydale Ave. And that was the first time we really saw neighbors knocking on neighbors' doors, pulling them out and saying, hey, there's testing over here. Part of the reason they were willing to come is because we were not labeled as UCSF or SFDPH. We were labeled as United in Health D10. You couldn't tell who was a doctor, who was a nurse, who was a community volunteer. People answered our surveys because their neighbors were asking the questions. Do you want to add anything?
Let's keep going.
Okay. Next slide. And I think this one too.
Is this me?
Yeah.
So yeah, oh no, that's you.
So we brought together really holding this concept in mind, which I think goes with cultural humility, right? We strive for competence in academia, which is silly, because like, do you need to score a 95, or is a 90 good enough on your cultural competence test for you to be competent in somebody else's culture? So cultural humility allows you to follow the principles of lifelong learning, and what that means is you have to acknowledge that everybody around you has something to teach, and that we all have something to learn. So we were able to pull together the public health departments on the institutional side. I'm gonna let you talk about some of the community partners. On the institutional side, UCSF Health, UCSF Cancer Center, public health departments in Alameda County, San Mateo, and San Francisco all sit on our weekly and every other weekly meetings. And then Kaiser came in with a lot of financial support, largely through shaming in Alameda County, which was very helpful. To say, like, what are you guys doing about equity? They're like, oh, we're giving money to Umoja. We're like, yes. And then finally, we've started to pull in the family practice residency from the San Francisco General with Dr. Anjana Sharma, and I'm really grateful to her. The medical students have started showing up. So those are, I want to mention those institutional partners, if you want to talk.
And then in the community, we had YCD, Young Community Developers, Bayview Hunters Point, YMCA, J&J, Mercy Housing, the Advocates, 3rd Street Youth, Rafiki, and also we had, Samoan Community Development Center was really primary in this. We had a really beautiful partnership across the services, as well as SFDPH wellness centers and Nurse Leo and other folks who really came out and helped. One of the things about that, though, was that at the beginning, we didn't even have protocols, if you all remember. So we were trying to figure out the protocols on the way. So I also want to give a big shout out to Center for Community Engagement, Roberto and Paula, Wiley, everybody from the team, Lydia. I see Dr. Grumbaugh over there. Because Roberto would call and say, what do you need? And I'd be like, well, I need somebody to come out and be out with me on this site because, you know, remember, we weren't putting our staff out on the front lines at that time. We were retraining them and repurposing them into either laying them off or moving them into contact tracing, case investigation with the city, or some of these other positions, but I was not putting my staff out on the front lines. So folks volunteered to come out in these very dangerous times from UCSF, but also I wanted to give a big shout out to the Latino Task Force. and specifically Tracy Brown, and to Mama Bear, whose name I'm, Val. I'm like, I know Mama Bear, but what's her name? Val Tuye Alewa, who came out and really showed us how to do the work. So on the first day that we did the United Health in D10, they're like, okay, you need this, you need this, you need this, you need this, somebody needs to go do this. And we're like, oh, okay. Oh, also Human Rights Commission and Dr. Director Cheryl Davis was phenomenal in working on and her team in working on some of those late nights with us.
Which also reflects on the electeds who were in it with us. So
Supervisor
Walton,
Watson was
very supportive
key in getting those first sites out and permits.
Yeah, permits, lots of fun. And then I do want to shout out Mayor Libby in Oakland, who actually did an executive order that allowed us to test wherever we needed to, because based on city ordinance, we were sometimes 50 yards too far from a clinic, which is ridiculous and also shows the structural issues that you would never have found out if you didn't try to get a permit for this stuff. So sometimes in Alameda County, we actually pop the tents up right in the street. So just to be clear, that policy piece is critically important to sometimes getting the work done to get over the structural issues embedded in our policies.
And so part of each piece of the puzzle is also the community shot callers, the folks on the ground who can actually mobilize people out. So I know some folks may remember this, but early on we had a bunch of young folks going to stripper parties and or hanging out, passing blunts around. I mean, COVID, right? You're like, don't.
But that's actually how we got called back to Sunnydale.
Exactly,
that
because
kind of
exactly
party
that's what I'm
with
saying.
One person who touched many households, and the credible messengers there, Larry Jones and Drew Jenkins, knew that this kid was going to infect 5 different households, and that's why they called us.
So so you have to have the folks on the ground who actually can get the people into testing or get them into care. So just want to really say that without those relationships, and even with my staff who went up and knocked on doors because he lived in the building and was able to bring folks down. So these are some of the key things that we got to recognize.
So we've gone over a little bit.
Oh, I wasn't even looking at you, Ron. I'm sorry.
I want to get to the last slide.
Let's do it.
Okay, so we just want you all to really absorb the fact that if you don't come out into community, you're not going to be effective there. And I just want to say there is a big difference between folks' willingness to be in the Latino community where, okay, we just need to speak Spanish, and if we speak Spanish, it's all great, and coming to the Black community where there is what we call proximity fear. And if you don't know what that is, ask one of your Black friends. Okay, that's the thing that makes people cross the street when they see a Black person coming. Clutch your purse, exactly. It's called proximity fear. So try to observe, try to call people out, try to help them, because it's understandable that people might feel afraid of something new, but that's no excuse actually for trying to impact disparities by being in the community. If you're afraid, you're not going to be effective. Okay.
That's right. Come on, can we say that again?
Okay, I think we're going to close up with this, which is that if you want what you have never had before, you have to do what you've never done before. So we have to start to do things differently. What I will say about this is that we are now using, what I want to say about this is, we talk about lessons learned. They are not lessons learned if you don't implement them again. They are just more talk.
That part.
So we're trying to be non-transactional. We're not just about COVID, and as we go forward, we've already expanded. We're doing colorectal cancer screening. We're doing hemoglobin A1C screens in community. We're about to roll out cholesterol panels as well, and we're doing...
Well, what we're doing right now is also recognizing that food is medicine and that people are hungry. So you got to give people what they need. And that, you know, people are not thinking about your survey. They're thinking about how to feed their children. They're thinking about how to pay their rent. They're thinking about, how not to get pulled over by the police. They're thinking about how not to be a statistic in their family. So all of these things really break down to real people in real time. So we got to really make sure that we're giving folks what they need, which means that in this food as medicine, what we're thinking about and what we're doing is co-locating a lot of the services so that folks will come when it's a bunch of stuff together, that they can get a service, they can check, they can get what they need. So another example is with Umoja Health. We're bringing in food boxes, hot food, and all the Mpox, the COVID vaccine, all the testing, all the blood glucose, all the stuff, right? And we want to keep
drumming circles and mental health, addressing mental health,
healing circles at the same time, all that. So last example, I want to invite you all to come out. Dr. Rhoads and I will both be there, but it's a Black family pregnancy and family pop-up, which is always second Saturdays on Mendel. Right down the street. So if you don't even know Mendel, you get to know it. It's right down the street. And come see co-located services, co-located epidemiology, co-located communities working together alongside UCSF and others.
And implementation of lessons learned in other diseases, so it's non-transactional. Last thing I want to say is, please stop doing outreach. We've been doing outreach forever. The disparities gaps are getting wider. So outreach doesn't work. It's unidirectional, it's transactional, it's cross-sectional. What we want to be doing is reaching out, because when we reach out, we expect a hand to reach back. We can see the assets and the values in the community that can be brought to bear and influence, as you've heard multiple times, how we need to be synergistic. You can't be synergistic if you're doing outreach. And then I just want to give a big shout out to our whole...
Oh yeah, everybody. Yay!
That's our whole network.
And with that, these are relationships, y'all. Do you know how much time goes into the relationships? So if you already have the relationships, you don't have to get ready, you're already ready.
That's right.
The big question I have, COVID was such an amazing thing in terms of bringing everybody together. It was the first time I ever seen in this country where everybody had the same priority. Like the government had the same priority, the community had the same priority, the researchers had the same priority, and it's going away, right? We're not prioritizing it the way we were, yet all these great things have been done. So how do we sustain it? And the key question here is, what does UCSF has to do to help this sustainability or this creativity that we're doing? Because we got the leaders of UCSF research here, Dr. Collar, Dr. Chung. Speak to them. We'll start with Erica, maybe.
Great, thank you. I mean, I think it's pretty basic. We need to invest, right? And we need to show return on investment. I think that's really a big thing I'm really learning. I think, in public health and clinical medicine, we don't really learn about how to speak business talk around return on investment, but clearly prevention and all the work we're doing and closing disparities is actually, there's a huge return on investment. It's not only a social return, but there is a financial return. And the more we can really show that, demonstrate, and give these long-term investments, I think in public health, I've been, actually my first job in San Francisco, DPH, was around infectious disease emergencies, and I've seen us, over and over again, we get the avian flu funding, and then we get the bioterrorism funding because there was anthrax, and then we got Ebola funding, and then but it's all like too little too late, and we need long-term investments. And I think, and really making part of that investment be community-based, reaching out and in true engagement, and really making sure you're looking at that spectrum of engagement and not just saying, and I love all the Arnold Perkins quotes, it's just awesome. So I'll pass it on.
I'll add two things to what Erica said. One is recognizing the value. I think often we do community engagement when we can't get numbers for our research, or we recognize we've stalled out, or we've gotten backlash. And that's way too late. It's also very transactional. So be in community when you don't need something from them. Work with community when there's not a high touch point. So for cross development of skills and bi-directional learning. So I think Dr. Rhoads can definitely speak to that. She's already taken Dr. K, so I guess I'll be Dr. KT. But but I think the other piece is also diversifying our workforce. We talk about it all the time, and we have meetings about it, and we have we look at wheels of numbers and pie charts and whatnot. It's not super hard, especially if you have key people in your workforce that already represent diverse communities. ask them how. I was able to stand up the most diverse workforce that my group has ever seen. And it did not take a whole lot of effort, but your networks matter. And you know people, you reach out to people who you know. It's the same across the board. So, I had bilingual Latinx, Latine workforce. I had people from Arab descent. I had folks who were from the Black community. And then if they're at UCSF, figure out a way to keep them here. We work in a soft money environment. When we see these funding cliffs come, prioritize your staff of color who've been working in community, who've made these collaborations and connections, because when they go away, those collaborations, connections may go away too.
I just want to suggest that we change what we think is valuable, because we all know that building these collaborations requires time, and during that time of building, sometimes there will be no outcomes that you can point to as a return on investment. One way that we're trying to amplify what we're able to do is, because our networks have FQHCs, other health systems, to drive, and we've basically ended up doing this, is actually shuttling people into UCSF, sometimes other places depending on where they live, for cancer care. Because right now, that's the return on investment, is like, can we bring business into the business that we're working in? I think we like to think we're in this research space and that it's sort of pristine, but it's actually attached to the health system. That's where all the money comes from. So that's, I think you have to pick your target for who you want to show that there is value added. And unfortunately, right now, that is actually about bringing business into the revenue generating side of life. But that's only because that's what we're valuing right now. We're not valuing these partnerships, because if we were, people would be lining up from our institution to give us money to continue this work. Instead, we're out there. I like to tell the philanthropists that I talk to, say, how are you doing this? I say, coins in between the couch cushions. Because it's not coming directly from UCSF in that way that says, we value this huge network that you're building. Even though our messaging developed by that network that you saw on that last slide has reached 19 million people, because we put those messages on BART. Who paid for that? Not UCSF. So I really want to ask us to think about, what do we value? Because if we really value these partnerships, that's where the investment will be.
That part. Oh, okay.
I messed up as a moderator. We're running over, so no more question, but you can ask them offline. But as usual, we're going to let the community people have the last word. Dr. Mo.
Thank you, Dr. Tung Nguyen. Thank you. I'm like, oh, wait, what's your last name? You know how you know somebody so well that you're like, oh, yes, let me just call you, hello, my brother from another mother, which I do, actually. So I'm going to say it really simply in two different ways. The first part is, I have over 50 examples of what not to do. So if you want to know those, maybe somebody could pay me to write them down. And put a slide deck together, and then we'll present it and pay us to do that. So it goes to this part, though, literally, seriously, because I work a lot of times for free or nothing or pennies for UCSF, so don't get it twisted. I volunteer here a lot as well. But what I want to add is that yesterday, literally, somebody working on a UCSF study reached out to me as their first Black person in there under one of the PIs. The whole PI project is around, and I don't want to identify it, so I'm going to say anti-racism. Let me leave it really open. And they were reaching out to me to pay me, I think, something like $5,000 to work with them for a year, giving them all the knowledge. All the other community organizations also were anti-racist, but they were all white organizations. So they had not included us as thought partners. They had not come out to the community and checked in. They did not have a relationship with us, or even bother to have a relationship with us until this Black researcher was there. So I had originally told my staff, no, we are absolutely not going to do this study. I'm not going to give my community, you know, $100 gift card to do this. It's insulting. I then, of course, dug deep, as I always do, to do the right thing and said to myself, look, I'm going to support this Black researcher because she's here by herself with these other folks, and I'm going to figure out a way to support it because could actually be transformational, what they're trying to do. But I told her, listen, I'm only going to do this if I can talk to the PI and I can be really direct about how, excuse my French, fucked up, insulting, and anti-Black and anti-people of color she was in creating her study. So this still happens every day. So y'all, I know I'm preaching to the choir in here, so I really appreciate you, and I really respect what you're doing. And also, you got to do better. So you got to listen to the stories. You know, Tung and the team and I have spoken often about a reparations, a truth and reconciliation opportunity. This has to happen. This has to happen. There has to be, your doctors need to come and do a co-located clinic at Rafiki, doctors that we've already approved, of course, to not do damage, or other co-located spaces, right? You have a lot, but this is the last thing I'll leave you with, and Dr. Gumbai and I talk about this, and I've challenged the team on this. You come out to the community because you don't have Black participants in your study because you don't have Black patients. The reason why you don't have Black patients, why don't you have Black patients? And how do Black people feel when they walk in the door? So I'm gonna leave those blank, let you imagine what those things might be. And just know that, you know, this is essential for Black lives in San Francisco. They're dwindling by the day. This is only, somebody's a statistician, 800,000 is supposed to be our nighttime population in San Francisco. 3%, generously 5%, how many Black people is that? Somebody with, who's a math person in here, y'all? 40,000 people. 40,000 people. And yet we just got the report from the tentative report from the morgue of overdoses. They're overall going down for Black people. Guess where they are? Still going up, still disparity. So let's get real, y'all. Do you want us here?
Thank you.